Hi, this is Kunal Patel from the University of Texas Southwestern Medical Center, and I'm going to present a case of a type A aortic dissection complicating TAVR. The patient is a 90-year-old female with a history of symptomatic calcific trileaflet severe aortic stenosis. She additionally also has a history of hypertension and non-obstructive coronary artery disease. Her STS-PROM was calculated at 3%, and after having a discussion with the patient and our heart team, it was determined that she would be a good candidate for transfemoral TAVR with conscious sedation and full surgical bailout if necessary. On her pre-TAVR imaging on the cardiac CT, we found that her annular area was 388. She had large sinuses and an STJ diameter of 25. We had sized her for a 23 millimeter Edwards Sapien S3 valve, which for her annular size was 5% oversized. Notably, on her imaging CT, we found that the majority of her calcification in the aortic root was limited to the native aortic valve, with very little LVOT calcification and just a couple of specks of STJ calcium. Transfemoral access was achieved without issue, and the patient's native valve was easily crossed, and the S3 delivery system was advanced to the and the valve was advanced to the deployment position smoothly without any resistance. In this video, we demonstrate the actual deployment of the valve, and so the valve deployment, it was done under rapid pacing. As we can see, and the valve was in good position, and the patient tolerated rapid pacing without any immediate issues. We performed an aortogram post-deployment to assess for any paravalvular leak, and as we demonstrated in this cine, a type A aortic dissection was now present. The dissection appears to be originating at the superior portion of the valve of the transcatheter heart valve at the STJ, and was not associated with any significant paravalvular leak, and it was not associated with any coronary involvement. At this point, we lightened the patient's sedation as she was under conscious sedation, and we determined that she was neurologically intact and she was free of any chest pain. Her hemodynamics were normal and stable off all vasopressors, and we performed a transthoracic echocardiogram, which showed no significant pericardial effusion. So we decided to take an initial conservative, non-operative approach, and the patient was transferred to the ICU. A CT scan was done en route to the ICU from our hybrid OR and demonstrated redemonstrated a type A aortic dissection sort of originating at the superior part of the transcatheter heart valve and extending 2.8 centimeters cranially. And notably, there was no involvement of the aortic arch, and there was no involvement of the major branches off the aorta. The patient's initial hospital course was very unremarkable. She continued to have no complaints, no chest pain. Her heart rate and blood pressure were very well controlled. She remained neurologically intact, and we repeated a CT scan on her second postoperative day, which showed mild extension of the dissection flap which was originally 2.8 centimeters on CT and now extended 4.2 centimeters cranially, but again, without any major arch or major branch vessel involvement. We discussed the surgical versus the conservative options with the patient and her family, and ultimately decided to continue to manage her conservatively with medical therapy. On post-op day 3, the patient was being prepared for discharge home and getting herself dressed when she experienced sudden onset of chest pain, loss of consciousness, and hemodynamic collapse. We decided to, en route to transferring her to the SICU, to get an emergent CT scan, which showed marked extension of the dissection flap into the abdominal aorta, with near total occlusion of the right common carotid artery, with dissection flap extension into the brachiocephalic trunk and the left subclavian artery. We considered operative repair at this point, emergent operative repair. However, the patient's family opted to forego surgery, and the patient ultimately passed away. This unfortunate case provided several important learning points for our team. Type A aortic dissections are a rare complication after TAVR and occur in well below 1% of cases. In our case, the dissection appears to have occurred at the time of valve deployment, likely caused by injury to the aorta by the superior portion of the valve. Others have described injury to the ascending aorta during the nose cone advancement of the valve as it traverses the arch and aortic root, as well as dissection caused by injury to the aorta during withdrawal of the pusher during the positioning. Although type A dissections in a non-TAVR population is a surgical emergency, in select high or prohibitive surgical risk patients who demonstrate 48 hours of stability in their symptoms and the size of their dissection, a conservative non-operative approach has been described. In TAVR patients, one small case series found that 3 out of 4 type A dissections associated with TAVR were successfully managed conservatively. Importantly, if an initial conservative approach is taken, serial CT imaging is critical to the early management of these patients. And as we learned in our case, even mild early extension of the dissection flap should prompt a very serious consideration of surgical repair, even in asymptomatic patients. Thank you.